Perianal abscess is the one which is situated at the abscess situated at the anal verge. If we not treat the disease, it may extend into all perianal spaces. Perianal area is the one which has loose tissue, and easily any infection can easily spread within no time. So it may lead to complications. If not treated, it may lead to dreadful complications like fecal incontinence. So why do we worry about it? Because the simple abscess will cause complex tract, and no method is like Hari said, there are many methods. No method is complete 100% treatment for the fistula. So the basic etiology for the fistula is the abscess. So when we want to avoid it, what we should know? We should know the thorough anatomy, and we should know the pathophysiology, and you should know the comorbid condition, and you should know what is the disease space, in which space it is present, and how to drain it, or what are the different methods to drain it, and what are the comorbid conditions, and also education of the patient, not the least. So in that we should know about the anatomy. In the anatomy, there are the anal glands. See, these are the anal glands. These anal glands are 20 to 30 in number, and these are present in the crypts, and they may present at any level. Depending upon the level of the anal gland, it can get infected in any space. So there are specific causes and non-specific causes. The specific causes, as Harish told, these are all the specific causes. This is the case of perianal abscess in a child who was hospitalized for fever and the diaper rash. The patient, after discharging the patient, he had again the fever. Then when examined, because of the diaper, patient has the perianal abscess and had repeated admissions. These are the other. So what is the pathophysiology? See, I told that there are anal glands. The obstruction of the anal gland will lead to stasis, like just sebaceous cyst. Sebaceous cyst, punctum is blocked, sebum is collected, infected, and then becomes an abscess. Just like that, perianal abscess is the perianal gland. Anal gland gets blocked and stasis will be there, and it can form abscess, and if not treated properly, it will become fistula. When there is an abscess, thus abscess may spread in any direction. So in what are the different spaces we have, we should know thoroughly. Here, see, these are the intersphincteric space. This is the perianal and ischiorectal, supralevator and retrorectal, supralevator. This is the deep perianal abscess and superficial postanal abscess space. In these spaces, the infection can be spread. So what symptoms we will see? Any abscess will have fever and pain, gluteal pain, because it is present in the rectal area. Rectal bleeding will be there, rectal pain will be there, and sometimes it can be accommodated with dysuria, retention of the urine, and inability to void. But if the abscess is in intersphincteric area, it will have vague pain, and if the abscess is very small, it may not cause much symptoms, and we may treat it as the fissure. It mimics fissure. So, like Harish told, when you treat the fissure, if the patient pain is not relieved, think of the underlying abscess there. Next is the perianal area, and if it spreads laterally, it can cause ischiorectal abscess. If it spreads above, it can cause supralevator abscess. In the supralevator abscess, we will have vague pain. Patient may have difficulty in sitting for the long time. That may be the only symptom. So if that constantly patient presenting to you, to your OPD with not able to sit, then go for examination under anesthesia. You can palpate the abscess. If the patient is having perianal abscess, the pain will be present and it will have swelling, small swelling will have, and you may sometimes think it as thrombosed pile. If it is very small, you may think it as thrombosed pile. If it spreads laterally, it's a very big space is there, is colorectal space, and it can cause pain. First pain and fever will come, and then the abscess, fluctuating abscess, you can palpate. So there are, what are the different types of the abscess means? Intersphincteric abscess, perianal abscess, supraelevator abscess, colorectal abscess. These are you have to keep in mind. Apart from it, deep perianal abscess. If the patient is having constant fever, fever of unknown etiology, PUO we will call, more than 20 days, go for MRI of the perineum, you may see deep perianal abscess. Another condition is there, floating anus. This is a classic horseshoe abscess. From the midline, it spreads to laterally into any one of the scapular fossa. Then it forms like horseshoe abscess, and the anus will look like floating in the pus. That is called as floating anus. So there may be different presentations of the perineal abscess, like Fournier's gangrene, scrotal abscess, gluteal abscess, because one of the space extends up to gluteus maximus. So you can get as a gluteus abscess. Bartholin disease, the patient has recurrent Bartholin, think of perineal abscess. Then how we have to investigate? Just distal rectal examination is the best one. You can feel the induration, and the patient will, venous and pain will be there. And after that, you can complete breath picture, leukocytosis will be there, and you can use ultrasound, transanal ultrasound, and endoscopic ultrasound, CT, MRI, like that, any investigation to confirm your spaces. Then management, how we have to manage. Although sometimes patients will ask, can we wait and watch? Madam, we don't want to undergo operation. No. There is no question of wait and watch in any abscess. It should be drained, analgesia should be given, antibiotics and proper irrigation should be given. So what are the different operative techniques? This is the incision and drainage. See, under examination and under anesthesia, you palpate it. You can see the boggy filling in one area, and the nearer to the anal area, you have to give the incision, not far away, because your incision may be the future fistula external opening. So, and you have to give the incision like this and drain the pus. Here also, in female, above the anal, at the vaginal side, you should be very careful, and you should not deal with roughly, because there will be blood supply and you will disturb it, and there will be a lot of bleeding. If the abscess, you are seeing intersphincteric abscess more towards the internal side, then better to go for the internal drainage. Just you open the, whatever the gland will be infected, no? Infected gland will be there, just you open the abscess cavity and drain it. You can put some catheter also there for irrigation. Next, how to deal with the horseshoe abscess. See here, in the horseshoe abscess, you have to give multiple incisions like this, because we have to deal entire pathology. See, give the incision there and go up to anococcygeal ligament, then drain the pus. It will be that much deep seated, then only it becomes horseshoe. Then give another incision laterally. After that, you will have internal opening. In that internal opening, that also should be treated. you have to irrigate it. Then put a catheter to irrigate all the area. This is very important. So, like Harish said, fistulotomy with abscess drainage. This also we have to think. So, very low lying fistula is there and abscess is there, fistulotomy and abscess drainage should be done. But we have one in those conditions where Crohn's disease is there. Yes, it's okay. I will complete. Crohn's disease and immunocompromised elderly patients and female with anterior side, you have to be very careful. This is the fistulotomy. And then drain the pus. Another one is the catheter drainage. Here you can, if not the seriously ill patients, you can put the catheter. Like that, you can give a stab incision and put the catheter. Catheter size should be equivalent to the abscess cavity, should not be less. And thoroughly irrigate, and after gaining good amount of granulation tissue, then you can remove the catheter. This is in some are trying to do minimally invasive under C-arm, putting the guide wire into the abscess and drainage. So, if the abscess is supragluteal, then drain internally, don't drain the outside. It will form a complex fistula.
If you decide to look for an internal...
So, post-operative management, good antibiotic with culture sensitivity, analgesic, sidge bath, stool softener should be given, fiber diet, and educate the patient about the complications. That is a must. And what are the complications? Scarring, fissure, abscess. Apart from this, some complications will be, we can see like this, the fistula tract from the root of the scrotum. See, you can see the dye coming through the perianal area. And sometimes carcinoma, because of the recurrent perianal abscess, sometimes, very rarely, adenocarcinoma may occur. This is the necrotizing fasciitis like that when it is not treated. So, recurrence. Why the recurrence? Recurrence is due to inadequate drainage, and if there is fistula, immune compromised, comorbid conditions, they will have recurrence. And apart from that, external disease like hidradenitis and perianal pilonidal sinus extending lowerly and Crohn's disease. This will have recurrence. So, thorough anatomy and adequate drainage, postoperative irrigation, sidge bath, proper antibiotic, and treat the comorbidities, then so that like that you can avoid the recurrence. So, what is the take home message? This abscess is a very simple one, like sebaceous cyst. Treat it properly. You don't get the complexities. Treat with the good investigation and proper technique. We can avoid. Thank you.
Any questions? I would like.
Yes.
Like high investment against Kaliweta.
Yes.
I don't think so. We need to wait till 20 days. We have 1%.
No, I have not told that waiting for 20 days. Patient may complain that from 20 days I am happy. If you have proper idea of the perianal abscess, day one you have to you have to proceed. Yes, you have to investigate and proceed.
Just a very small comment, madam. We know everybody that the perianal abscesses are very obvious in diagnosis. So, what is the complication? Which is the difficult abscess to be drained? That is the intra-anal abscess. When the patient is not having any external opening, patient complains of any pains, some perianal tenderness, and patient is presenting with fever. Sometimes it is misdiagnosed by many of the persons that patient is having proctalgia, and that is because of the fissure. As in this type of diagnosis are done by the general surgeons also. So now question remains, if there is a very small intra-anal abscess, means just sometimes at the dentate line at 12 o'clock or 6 o'clock position, So if the abscess is very small, only pricking the thing at the site and just opening the abscess will definitely do what you have shown in your video. But if the abscess at that juncture, if it is large abscess, very large, going very deep down up to 3 inches, it is going inside. So problem lies over there where when that time, even if you drain it out and if you put something inside, that the thing will be more complicated because the healing process will be very difficult. That is inside, so nothing is washed outside. So what is to be done in this way? In this condition, what we have to do that it is not to be incised at the only juncture of 6 o'clock, only not a small incision, but it should be a radial incision going not less than 1.5 inches. So radially you should incise it in the intersphincteric groove. Jitna bada, if you incise it more, the problem is healing is a problem because healing should start from inside out in any of the abscess. So if you open it in a very small external opening you have created, so it will heal earlier, but the remaining cavity would be there inside, so that there will be recurrences again and again. So in this juncture, what you have to do is you have to incise it in a radial fashion. So at 6 o'clock you have to incise it radially, give a large incision, 1.5 inches I tell you, and then make it free, and then leave it. So within a period of 15 days, it starts healing from inside out. Now outer you don't have to care. And again one thing, one of our senior surgeons is from Bhopal, and he has devised it. Actually, I should not declare it oral because it is under the presentation, it is under the paper publication, but I will still show because I will tell you because it is for the interest of everyone. What he wants, what he does, he packs that cavity with proline mesh. Alternately, without proline mesh, you can use a mosquito net also. 0.5 centimeter in diameter, you create a strip of that mosquito net. 0.5 centimeter. So you make a strip of that. You can do it by proline mesh or you can use a mosquito net also. And you pack that cavity. You have drained out the abscess, you pack that cavity, and from the very next day, what you have to do, you only instill the saline and betadine inside, and every day you have to remove 2 inches, 2 inches, 2 inches. That strip is to be removed and cut. So this will be definitely give less pain in dressings, because whenever you do the IND, the dressings are all the time painful. So in this case, what he has, that strip is there because the mosquito net is there or the proline mesh is there, so it will ask for the good amount of granulation. I have seen that, I have done it, though it is not published in the literature, but it is under he has asked me not to say anything about, but I am still for the benefit of everybody because this is the very difficult case. Intraanal abscess is a very difficult entity when you will be feeling. Even if a large abscess is there, it is very obvious. Thank you so much. We have to wait for this studies to come outside.
Hello.
I now request.
Sir, can I put a
What
word?
Madam was telling about the complication, and 2001 I saw a patient who came late with fever, pleural effusion, 18 years old boy, admitted under medicine department 2001. Ultimately it was found to be ischiorectal abscess, which has gone to the supraelevator compartment, dissected retroperitoneally, perforated the diaphragm and gone to the pleural space with a chest collection. And I was draining the ischiorectal abscess. If I give wash in the ischiorectal fossa to the chest drain, the betadine solution was coming out.
Sir,
This is the ultimate thing I have seen. Long time back, 2001 it was. Only patient fever, respiratory distress, admitted under physician. Primary cause is ischiorectal fossa. Thank you.
Madam, 1 minute. Madam, I congratulate you for a wonderful speech of such a complex issue. Ladukar sir, I want to add something. What you told is very right. Patient comes with a perianal pain, fever, inflammatory signs, etc. No signs outside, everything is normal. You put a finger inside, you have a deep, tender mass. It is really difficult. You want to open internally, you want to make an external incision. I would rather open internally only and leave it. I would not dare to put an external incision for a fear that you may develop external, etc., etc., etc. The second thing is, you are very much right. Even today, I am not convinced. Imagine there is an abscess inside the anus, about supralevator place. You have opened inside. What is the course of the disease? God only knows. Thank you.
Sir,
If I am wrong, please correct, because this is still, I am not convinced what to be done in this situation. A supravellator abscess, shall we go boldly and open it from inside and leave it like that, or should we do something more? You have to put a Foley's catheter inside and wash. Okay.
Patient was there because of the constipation he has taken enema. Because at that enema tube caused the trauma and patient developed deep perianal abscess. That we trained internally, and last month I don't know why there are 4 patients I encountered, each with the pain while sitting, and each will have, after perianal ultrasound they have less than 1 centimeter abscess.
that is very true. This is very important. Very mischievous. In context with Dr. Ladukar sir, whatever that proline mesh inside, but my take on this is keeping multiple sit-ons to keep the mouth, external mouth open. That is the commonest thing possible. Second thing is in relation with the perianal abscess, I have encountered same patient in 2002. Patient was morbidly obese. Patient was having the infertility treatment and she conceived after 10 years of marriage. Patient had a small perianal abscess. She was visiting to the gynecologist repeatedly with fever of unknown origin. Then when the gynecologist used to ask related complaints, she was only complaining of fever. Because of morbid obesity, she has not dared to examine her perianal and pervaginal area. On the 50th day, and 9 months ANC, she presented with a very high grade fever. Then patient was referred to me. On the day when she presented, she was having perianal abscess with multiple vesicles on the anterior abdominal wall. They were filled with a gangrenous fluid and it was smelling like a gutter. You will not believe whatever I am saying. No, but her husband was a pujari in some mandir, and after examining that patient, I really felt ki what to do. After explaining that she may have to succumb a life and death situation because of this septicemia which she is encountered, they have taken a decision. I have taken a decision to land up her into the ICU without anesthesia, debriding done. Anesthesia because she was not in a condition of any type of anesthesia. Multiple, you will not believe that anterior abdominal wall which was there studded with vesicles, the debridement was done and maggots were coming. Complete peritoneum till peritoneum, everything was necrose and there were maggots. Then perianal patient was on BiPAP. Really for 15-20 days I used to debride this, complete isolation from the ICU because so bad smell of the patient. And after 1 month, for every type, she was on the nutrition and all types of diet advice and all. Per rectally, I used to put my hand and manually remove the feces. On 25th day, patient had a raw area of abdomen. That pregnancy, she landed into a IUD. There was a complete death of the fetus and all possible sequelae which is quite evident. The complete raw area which was there over the abdomen, that took next 3 months to have the complete granulation. Then I have done the CT and MRI of the patient. After complete mobilization, physiotherapy, this every hat I have own on my head, and physiotherapy, dietitian, mobilization, everything. And after again 3 months, I took her to the skin grafting. That raw area was covered with skin grafting. After that skin grafting, she was okay for few days. After 1 year, that whatever skin grafting was done, and there was no anterior abdominal wall because of the muscular atrophy, she developed complete defect in the anterior abdominal wall. From this mid umbilical to pubic symphysis, there was no posterior strength. So whenever she used to stand, complete intestine was going till thigh. This was after 1 year. Then the same patient was managed by me and Dr. G.V. Rao at Asian Institute. We had pushed, TAR was done, and subcostally to pubic symphysis, complete repair was done. So I was along with the patient in the Asian Institute. So for a simple perianal fistula, what can land, this is one of the important message. And after that, managing that case, Dr. G.V. Rao sir has written me a complete big letter of congratulations that is still with me. So the thing is, when you know the disease as such, the proper disease, how it has happened, why it has happened, then only you are able to know what to do and what not to do. So the message is very clear.
Yes, madam. Thank you.
Whenever you take any abscess from abdominal cavity or anything like that, it comes as SCJ coli, think of perianal abscess.
I now request Dr. Harish Gowda sir to present the memento to Dr. Madhavi Shamla ma'am. Thank you ma'am.